Thank you, Dr. Banshi Sabu, and thank you all for being here in such large numbers. It's always, every year we ask the question, with a great strain for us among all our research work to conduct this meeting, very honestly. Every year we ask ourselves, should we do one more update or then leave it? And then by the end of the meeting, everybody is coming and asking, when is the next date? So that is why we continue to organize this, and thank you all for your support. So this is a Sanofi-sponsored meeting, and so we will be discussing Sanofi products. But what I'm going to do is to give you a general introduction, and the two main speakers are going to be Dr. Banshi Sabu and Dr. S.Chawla, and they'll be taking the subject forward. So these are my disclosures, and this is supported by an unrestricted grant from Sanofi. So let's start with this particular, you heard all about INDIAB in the previous session, so I'm not going to talk about INDIAB, but this is another big study which was conducted in India, called as a landmark study, and this was to study the prospective observational real-world evidence in management and complication of diabetes. And this study threw up some very interesting and actually alarming, worrisome results. 63% of patients, and you saw that in the INDIAB, it matches exactly that. So 63% of patients have an A1C above 7%, which means hardly 30-40% have their A1C under control, if you take the whole country. And more than 57% of patients are on 3 oral drugs. Now, we know that we have 7, 8 oral drugs. So we as physicians, diabetologists, endocrinologists, practicing diabetes and endocrinology, when one drug fails, we add another one. When that fails, then we add another one, then another one. We think all the 8 we have to use. The truth of the matter, as we will show you, is that after 2 oral drugs, the effect you get is very minimal, and probably the side effects will start increasing. So if somebody has a A1C of say 12, and then you add one more oral drug to metformin, and anything is going to come down to 7, guess again, it's not going to, because maximum will come down by 1 or 2%. So you know from the beginning that you're doomed for failure, and that's what's happening. But we still think, no, if I add now SGLT2, it will come down, if I add GLP, it will come down, or oral, and so on and so forth. It really doesn't. And then a lot of people are obese in India. We also have lean diabetes in India, and a large number of people have micro and macrovascular complications of diabetes. Now, it's not just the microvascular complications, but we get macrovascular complications at a very young age also. And while for macrovascular complications, we always believe that glycemic control is not important, and that myth came from the UKPDS, where of course, retinopathy, nephropathy, neuropathy came down in UKPDS, but for macrovascular complications, it missed statistical significance by 0.02. 0.5 it should be to 0.52. Therefore it's not significant. People forgot the 16% reduction just by glycemic control. So don't forget the importance of glycemic control also in macrovascular complications. So we have to break this vicious cycle and make it very important. Get the sugars under good control. Now, this is what I said, that whether you take 2 drugs or 3 drugs or 4 drugs or 5 drugs, what you're going to get is a decrement of the A1C by 0.2%. Okay, so if it is 9.4, you will get it to 9.2. Is it worthwhile to add that just to keep on adding because patient says I don't want insulin, so you keep on giving, and because we also it saves us time. If you don't start insulin, 5 minutes, 10 minutes of our time is saved. So if the patient says next time we'll see, okay, good, then I'll write one more drug, and it becomes easy for us. But we are doing a disservice to the patient, because every month, every 6 months that they have uncontrolled diabetes, you are increasing their risk of developing complications. And obviously people who take insulin had better diabetes control. So now how do we start insulin and how do we go about it is going to be the rest of this symposium. The ADA says that basal insulin alone is the most convenient initial insulin. And indeed it is. When you're starting insulin, as I'll show you in the next slide, first you have to fix the fasting, because if you don't fix the fasting, how are you going to fix the postprandial? So that makes in the night, if you give a long-acting analog of insulin, which is very safe and won't produce hypoglycemia, you'll fix the fasting, and then the rest is easy. And then when that doesn't work, you can then think of the next thing. And all the associations are roughly saying the same thing. But 4 crucial factors influence the selection of appropriate insulin. First, it must be efficacious. What's the point in giving something that doesn't work? Second, it must be safe, and the 2 things you're worried about is hypoglycemia and weight gain. These 2 should not be there, and the analog insulins definitely score there. Convenience is very important. because you tell people to take 3 times, 4 times insulin, it's going to be very inconvenient. Of course, cost also is a very important factor because people cannot afford many types of insulin. So, with respect to this fixed fasting, first with basal insulin, as you can see the graph here, what you are seeing is that the fasting itself is so high. Okay, this is a continuous glucose monitoring, and you can see fasting itself is 250. And then naturally when you start there, it will only go higher. It's not going to go lower after you take food. So the main thing is to push that down, and that's what happens when you give the basal insulin. Now you have brought the fasting down, and when the fasting comes down, you can see automatically the postprandial comes down. So without fixing the fasting, if you are trying to control postprandial, it's a waste. That's the first step that you have to do, and how to go about this will be discussed by Dr. Banshi Sabu and so on. Now, does this last? And here is glargine U100, which has been added to oral drugs. And is it just for few weeks it works? No, here is a study where it's showing you that of course you might have to titrate the dose and give it a little more as you go along, and that's another thing that we are scared to give, because we are scared that, oh, how can you give more than 15 units of insulin? Right? Now, in our mind we have a block saying that, oh, we can only give 14 units of insulin, we can give only 16 units of insulin. I had American scientists who have come here, diabetologists in practice who have come here, and when I was telling them, I use 50 units of insulin, 60, I'm scared. And they say, are you joking? We use 700, we use 800, Then I felt reassured, oh no, 50 units are getting scared. They are using 700, 800, because they get really obese people and who need lot of insulin. Of course, today other treatments have also come, so you don't need to use that much insulin. But this is just to show that it can be sustained for a period of time if you give the insulin. Whereas the oral drugs, you will get from 8.7, 8.4 it will come. That's not enough. You not achieved the target. Remember that even 7 is not normal. 7 is just an accepted limit for a person with diabetes. The normal value is 5.6. We are not even talking about all that. We are only talking about some guideline value to reach. So I'm going to end by saying that glargine U100 is a very nice, it stood the test of time. Basically, it's been around for a couple of decades now. Safe insulin, no hypoglycemia, no weight gain. We've all used it in tons of our patients. It's efficacious. It can be used in elderly, no problem. 80-year-old person, you can still use it. It's efficacious in hospital patients also, outside also. It can be used in children over 2 years of age. So even in a small child, you can use it. CKD. You're always worried in a long-acting insulin like glargine. Can you use it if you have renal failure? Enough studies to show that even in stage 3 and stage 4 of CKD, you can use it. Pregnancy, if indicated, you can use it. So we've all used it during pregnancy and it's very good. And of course, CV safety is also there. So it seems to be an ideal insulin, just stood the test of time. And to take you more into the details of this, I would now invite Dr. Banshi Sabu to give the first talk. Over to you, Banshi.